Dear colleagues, in partnership with Nephrology, Dialysis, Transplantation, NDT, the official journal of the European Renal Association, MARKUS HOMe welcomes Professor Katherine Tuttle in Seattle, Washington State, Dr. Valerie Luyckx in Zurich, Switzerland, and Professor Tobias Huber in Hamburg, Germany, for our Best of ERA 2024 discussion. Dear Kate, Valerie, and Tobias, it's a blessing for us to have three global leaders in nephrology. Thanks so much for joining us a few days after the iconic annual meeting of the European Renal Association in Stockholm, Sweden, which has been coined as the best meeting ever by the Renal Science Chair Danilo Flieser today. Professor Katherine Tuttle is Clinical Professor of Medicine at University of Washington School of Medicine in the Division of Nephrology in Seattle, Washington State, and Director of the Providence Medical Research Center at Providence Inland Northwest Health in Spokane, again, Washington State. Dr. Valerie Luyckx is nephrologist at the Children's Hospital of the University of Zurich, Switzerland, and chair of the Advocacy Working Group of the International Society of Nephrology. Dr. Tobias Huber is professor and head of Department of Nephrology, Rheumatology, and Endocrinology at the University Hospital of Hamburg, Germany. Today's hosts are Markus Seemann from Vienna and Andreas Kronbichler from Innsbruck, Austria. And before I switch the mic to Andreas, I would briefly say congratulations to all of you for doing this fantastic work. So we join here main authors of two of the three New England publications published during this meeting, and we currently schedule a third talk. And also to Andreas, because he has received the ERA Eberhard Ritz Award for Young Investigators in Clinical Science a few days ago. And those who are as old as I am still remember Eberhard Ritz as probably the most important nephrologist in Europe in the last decades. So Andreas, up to you.
Thank you, Gunnar. So I think I can just second what you said. It was really an amazing ERA, and at least I met Markus on the plane back, and I met Professor Huber during before the reception of the Young Nephrologist. So it was a great pleasure to have interactions again with all of you. And of course, I can also say nephrology has a momentum, and we are really proud to have such a meeting here online tonight. So we will start with the anti-nephrin antibody story. And I think most of us have learned nephrotic syndrome to distinguish into minimal change disease, FSGS, and membranous nephropathy. Then there was an attempt to put MCD and FSGS together and call it podocytopathy. But I think what we have learned with this landmark publication is that a lot of children do have anti-nephrin antibodies. Adults do have them at a lower percentage, and actually a sizable proportion of patients with FSGS also is positive for anti-nephrin antibodies. So it's definitely worthwhile to rename or reclassify, and as with membranous nephropathy, actually place the pathophysiology and also the presence of antibodies at the forefront and rename these diseases into anti-nephrin antibody positive nephrotic syndrome. But with this, I would like to hand over to Professor Huber to present some of this exciting data.
Yeah, thank you very much, Andreas. You summarized the data already so nicely, which is really already the key summary. So first of all, I think it's important to really, I would like to thank the teams at the beginning, because it was such a team effort. It was important that, you know, people who were in charge of the registries, were opening the registries, were joining together. Also people who had done previous work on anti-nephrin antibodies like Astrid Weins. And I would really like to name the key cohorts from Paris with Julien Ongon, with Pierre Ronco, from Bari with Tino Gesualdo, from Rome with Marina Vivarelli, from Hamburg with Elion Hoxha and others. And I would like to name the key authors, the first author, Felicitas Hengel, and also Nicola Thomas, who was one of the key senior authors of the paper. Now, basically, and as you quickly summarized, we are living in an age where we try to endotype kidney diseases beyond the descriptive phenotypic description as we have been used to. And there, probably in future times, there won't be something like minimal change or FSGS, but we are naming the diseases by the pathobiology driving these diseases. This is the next step And I think our example with the anti-nephrin antibody is really showcasing such an example. Our work really is building on a long discovery journey, which I also would like to mention, a quarter-century discovery journey, which all started by the discovery, cloning, and description of nephrin, actually in Stockholm, where we are just all coming from the ERA meeting by Karl Tryggvason, describing nephrin as the core component of the kidney filtration barrier at the time. And by that, opening a whole new research arena by understanding genetic kidney diseases of a nephrotic syndrome, but also the ultrastructure and mechanism of filtration. Since this 25 years of a description of nephrin, shortly after, anti-nephrin antibodies have been described. So describing anti-nephrin antibody was not new. The first one to describe it actually was David Selt, but also Suman Chak, who used these antibodies experimentally, applying them and inducing nephrotic syndrome in animals, showing that these antibodies are obviously interfering somehow with the filtration barrier, and that this interference has the capacity to somehow interfere with physiological function of the barrier and inducing proteinuria. And then later on, anti-nephrin antibodies were shown in recurrent FSGS cases in transplant patients. Most of them had actually mutations in nephrin, so congenital nephrotic syndrome patients. And again, there these antibodies were shown, and then later on they were even shown in type 1 diabetes, and there, which is not very clear at the time whether there might be an anti-nephrin antibodies also playing a role in destroying beta cells in the pancreas. I think it was never confirmed. And then the last in this series of findings was Astrid Weins, and she showed anti-nephrin antibodies in 18 cases of minimal change disease, suggesting a role of these antibodies also in a broader sense. The difficulty has always been to detect these antibodies. So apparently, this is a low titer disease. And when we used, for example, different patient sera and Western blot analysis, we were not able to detect recombinant nephrin in Western blot analysis, which is very different from membranous nephropathy, regardless whether we use reducing or non-reducing conditions. Same was true when we applied regular ELISAs or even ELISAs with enhanced techniques. We didn't get clear signals. And this caused so much confusion over the last years because many centers could not detect or reproduce anti-nephrin antibodies. For that reason, in Hamburg, Felicitas Hengel and Nicola Thomas moved forward using immunoprecipitation, using nephrin as a bait, by that enriching the antibodies that were capturing this bait. And then detecting on Western blot analysis now a very clear signal, yes or no. And based on this technique, we even moved one step further, where Felicitas, Nicola, and also Silke Dede invented a new assay, an ELISA hybrid IP assay, where they used the precipitate and eluted the precipitated strep-tech nephrin and used this on a plate, now on an ELISA. And by that, for the first time, we were able to really quantify antibody titers. Equipped with these techniques, we could move forward. And then it was important to have very well phenotyped cohorts. And it was interesting when we went to the cohorts of Bari, Rome, and Paris, and of course our own. Everybody was very skeptical. Everybody was unsure whether there would be nephrin antibodies and whether they could be detected. So everybody was saying, we sent you the samples, we give you, so what, no information, just numbers. Please measure with your yes and no signal and send us the results back. And you know what happened with all 4 registries? When we did send the results back, everybody was picking up the phone, almost close to tears, saying, we really can absolutely not believe what you measured. There is such a clear correlation to proteinuria, to nephrotic onset, to our controls, to onset. This is beyond everything we ever imagined. And this was then really the study, working then with phenotypes and correlating it. So, and then we could show, and this is the important result number one, it associated in treatment-naive patients a minimal change in adults, 70%, and in idiopathic nephrotic syndrome, treatment-naive, nephrotic, 90%. So I guess we can remove the term idiopathic. It's gone. It's an anti-nephrin autoantibody disease. Now, the next question, of course, was, do these levels correlate? And then we looked on the course and the patients that we had with sequential follow-ups, and there was a very clear correlation of antibody positivity to proteinuria and relapse to proteinuria. This was step number 2, and step number 3 was then also quantitatively measuring it in cases where we saw frequent relapses and correlating the titers to the relapses. And step number 4 was that we used these titers for prospective treatment of a few patients, where we, based on high titers of a relapse, applied rituximab, and then the titers basically, and with the disappearance of the antibodies in the titers, the disease disappeared. And then the next step, which was really important, was looking for us for the pathogenicity. So again, Felicitas and Nicola Thomas developed a mouse model of active immunization. And in this model, we had a rapid onset nephrotic syndrome and minimal change-like appearance on histology. By immunogold, we saw IgG sticking to a slit diaphragm. And by molecularly analyzing, we could see that there's a significant phosphorylation of nephrin in response to the antibody binding, and in response probably to this tyrosine phosphorylation on proteomic analysis, which was done by Moritz Lassé and Markus Rinschen. We could observe a shift of cytoskeletal proteins, of actin-bound proteins, of slit diaphragm-associated proteins, basically all being in a pathway describing food process effacement and morphological changes. Now, there's one fun aspect to me personally, that to get, in a team, we have been the first to describe nephrin tyrosine phosphorylation over 20 years ago at the beginning of this century. When we also cloned the Neph family of proteins and predicted slit diaphragm signaling, and now it all came basically back from describing the slit diaphragm signaling towards food process regulation, not just as a consequence of genetic diseases, but now also of immune-mediated diseases being induced by antibodies binding. Of course, and that's important to say, by finishing, there is now also on the mechanistic part, lots of more work to be done to better understand exactly the sequence of molecular events, which we are now just, speculating about. There is a massive need for more follow-up clinical studies and trials. So this is not the end, but rather the beginning of a discovery journey, which we are looking forward with, of the whole community now carrying this forward, and with all you together as well, and also as a journey really, which was caused so much excitement at the ERA meeting across all fields of nephrology, including transplant medicine, that we better understand the mechanisms of disease, have tailored therapies towards it, and now can really enter this area of precision nephrology.
So, well, thank you very much for this very engaging presentation of the data. And I think, it speaks for yourself that you know all of this actually in very great detail. So 2 quick questions. So when is a commercial test available, or do you think this will become a Hamburg-based investigation so that we can still send samples to you and you measure it as we have done before?
So the goal needs to be that there's an measure and test out there for everybody. This cannot be, centered at one university and owned by one university, because globally people want to measure these antibodies and tailor their therapy towards it. So we will be happy to help everybody with our immunoprecipitation assay number 1, and And there are now companies based on a Harvard patent developing high sensitive ELISAs, and I guess companies will be much better suited to eventually also achieve a simple, clear, straightforward ELISA, which was not possible academically, obviously, and that's why we did this IP hybrid ELISA. So I'm really hoping that there will be reliable ELISAs being developed as we speak, but this will take some time. And meanwhile, we of course will develop our quantitative assay further ourselves. I'm not sure whether this can be brought to the market independently, but we are really happy also to share our protocols for the immunoprecipitation and the people to talk to in our field, in our department, will be Felicitas Hengel and Nicola Thomas.
And another one, of course, how soon after treatment and how soon after patients achieve remission do you see disappearance of these antibodies? Do you have any information on that for us?
Yeah, great question. And this is something that we actually learned, and which is an important message for us. We need to be more rigorous biobanking, because in most of the biobanks and repositories that we used, we had an initial serum sample at onset, and then the next sample was a few months later. So we didn't have a very, very close follow-up of sample collections. So we had way too few samples to really monitor the disappearance of an antibody in response to a therapy based on a really daily or weekly granularity. We could just say, you know, there was an antibody at the beginning, there was a treatment, and then somewhat later, proteinuria gone, antibodies gone. But this is something that we really would like to understand, particularly in the pediatric community or patients where we see such a rapid response to steroids, and whether this response really correlates to the disappearance of antibodies, or whether there are eventually direct steroid effects on the podocyte, which eventually are stabilizing the podocyte and thereby stabilizing the proteinuria, and then the antibodies are disappearing just in the second phase. This is not known yet. And is one of, you know, I mentioned that there are so many follow-up studies now required, and this is certainly one of them where we need to look much closer, more detailed into the dynamics of the antibodies responding to immunosuppressants and the response to proteinuria.
And if I may just sum up here, so if you want to learn more about podocyte biology and treatment, next year in Hamburg, there is the International Podocyte Conference hosted by Professor Huber. So now I hand over to others to ask questions.
Yeah, first, congratulations, Tobias. I think your teams, you made, I think, history. And as I'm just looking now, Roland Garros in Paris, there's this famous sentence, victory belongs to the most tenacious. And I'm relieved now that yeah, you solved it somehow. Because first, when we had Astrid Weins here with us, she told us her stubborn story that she always saw some background fluorescence, and she dig deeper. And when I confronted our pathologist, just as you explained it, they were very suspicious. They said, nah, we don't believe that really, and so on, obviously due to these problems that you said. And so obviously you also believed in that, but she had one case of FSGS, and when I remember your presentation correctly, in this so-called FSGS, whatever this is, there was only a minor part that were positive. So we as clinicians always had this heretics, such as FSGS is the bad brother of the minimal change. So this is no longer true. And Swapnil Hirimat twittered, goodbye minimal change disease. So we have obviously a new era where we can have a goal-directed therapy. So what do you say in this FSGS or podocytopathy field? Can we leave it now?
Yeah, of course we can't leave it. It's a lot of more fit to be done. And I like, you know, what you and also Andreas did. The primary FSGS has not been solved yet. We see these antibodies just in the minority of cases. And then when I talked to Astrid, you know, when she saw this kind of foggy IgG staining, you know, which is difficult for some of the pathologists to see, but she didn't see it in also very few cases of primary FSGS. So probably most of the primary FSGS cases are not being caused even by autoantibodies. So there will be surely a small fraction of other autoantibodies, maybe other diaphragm proteins, something that we and others are now looking into. But there will be certainly other, probably circulating factors causing FSGS. So in this sense, probably these diseases will differentiate on the level of a pathobiology driver, the initial hit, but also in terms of a response. Because when we looked on podocyte loss and these minimal change, anti-nephrin-based minimal change cases, we didn't see a loss of podocytes, which we clearly see in primary FSGS. So there are different hits that either lead more to a functional opening of the filter or to an injury of a podocyte, ultimately leading to podocyte loss. So this will be different. Now, we cannot rule out that there are some cases of primary FSGS where there is an antibody, plus maybe second or a genetic architecture underlying that then also in the presence of anti-nephrin leads to podocyte loss. So there will be all, you know, shades of different pathobiology. So don't leave the field. Please come all to a podocytopathy field. The more people are working on it, the more people are joining in, the better it is. And it will be joint fun and no, you know, not in a way competition, but solving problems together.
I would love to add one question. Do these findings already affect your treatment in Hamburg now? So are you less reluctant to give rituximab? Did you change your clinical practice?
Absolutely, it does. And you know, since our assay is not officially certified, you know, it's then an individual health-based or individual case-based treatment, what we are allowed to do in German university hospitals. But Gunnar, we do this absolutely. We do this absolutely. So basically, when we see high titers, then we usually now treat, particularly when it's the first relapse, you know, we treat with rituximab, number one. If we see rituximab is not removing the antibodies, because we know, you know, there are plasma cells that are sitting in whatever different tissue compartments, then we also would consider moving on to daratumumab, CD38 treatment, and so on and so forth. So, and same applies, we have cases of recurrent FSGS post-transplant. And of course, we would now never go into and retransplant in somebody where anti-nephrin antibodies are still present. So we would go, you know, start with rituximab, and then from there consider further treatments if rituximab alone would not remove the antibodies, but not go in and retransplant before the antibodies are not replenished. What I'm saying right now is not evidence-based medicine. It's important to make this sure. I don't know how broad it is being broadcasted, but this is not evidence-based medicine yet. That's why we need to do prospective trials together. And I know that Andreas is trying to set up such trials in Austria and beyond. And these trials will be extremely important. We need these trials.
Maybe one
also implemented in KDIGO. Everything else is just
maybe one immunological questions, because of course we saw some aha again memory with regard to PLA2 receptor autoantibodies. They do not respond to steroids via minimal change, just respond. So is the immunological memory somehow harder in the B-cell repertoire of the membranous nephropathy in contrast to the minimal change? Do you have any clue on that?
No, it's a great question, and it's a great question mark as well. No, we don't know, but your observation is absolutely true. So first of all, we see it more in the younger population. It's probably, we see it in many cases being infection associated, and we see a very different response. And we need to better understand the B-cell biology. So that's also why it's so important with our registries and biobanking that we are collecting PBMCs now a lot. We need to study the B-cells, also see what they are, where they are, and how do they respond. Markus, lots of things to be done.
Yeah, because it fits with the clinical observation that adults need much longer to respond.
Yes.
So the memory repertoire is already established.
Absolutely. I think there is, and this is probably being explained in a different immunology of the B cells. Absolutely. Great comment.
So I think in the interest of time, we need to move ahead, and I will briefly present, I think, 3 trials which have not published yet, but have also been presented during the recent Congress. So The three trials are iptacopan, factor B inhibition in C3G, atrasentan and ETA in IgA nephropathy, and then lower dose glucocorticoids plus active vitamin D in minimal change disease. And I think the clear outline here must be that most of these diseases, especially C3G and IgA nephropathy, as can be seen here on the right side, have a really bad prognosis. We recently had Danny Gale here, who spoke about the RADAR trial and their findings. And I think we need to do better to treat these diseases. So the first one is the Beer C3G trial. It was presented by David Kavanagh, and it's not published yet. So I'm just showing the slides he presented there. So clearly, what has become apparent is that C3G is definitely caused by alternative pathway disruption. And so the rationale here is that iptacopan, which is a factor B inhibitor, is actually reducing complement activation and thus also portends a protection for kidneys. So here's the study design, and the trial has completed recruitment and has already hit the primary endpoint analysis, and that was presented during the meeting. 74 patients in total were randomized to either receive iptacopan, 200 milligrams BID, or placebo, and then there is an open label extension where all patients received iptacopan treatment. Primary objective at 6 months, superiority of iptacopan versus placebo in the reduction of proteinuria, and here they used 24-hour UPCR, and a key set of secondary objectives, as you can see here. Patient characteristics, so 38 patients randomized to iptacopan versus 36 patients to placebo. And you can see that the baseline UPCR was slightly higher in the iptacopan-treated patients. The age was pretty much balanced. But if you look at the subtypes actually of C3G, which were recruited into the trial, then more patients in the placebo arm had C3GN in comparison to iptacopan, where more patients had DDD. So this is basically underlying that those patients randomized to iptacopan had worse clinical predictors, so higher proteinuria, and also DDD is actually worse in terms of treatment response. This is the top line result, actually also presented by Novartis a couple of weeks ago. Iptacopan achieved a statistically significant and clinically meaningful reduction in 24-hour UPCR. We can see a minus of 30.2% here in the iptacopan-treated patients in comparison to 7.6% increase in UPCR in the placebo arm. This is highly significant despite actually the low number of patients randomized in this trial. Secondary results, proportion of patients who achieved a composite renal endpoint that was defined as an over or equal to 50% reduction in UPCR, plus a lower or equal to 15% reduction in eGFR. And again, you can see that iptacopan was superior to placebo, and that was mainly driven by the proteinuria reduction seen in these patients. Then they compared actually the eGFR slope before going into the trial and then during the 100 days in the clinical trial. And you can see that they had a pre-treatment slope of minus 7.35 milliliter per minute. And after treatment, this stabilized and actually had a bit of a positivity with 0.9 milliliter per minute. So not only they showed a significant reduction in proteinuria, but also, at least for the short term, a preservation of kidney disease once iptacopan was started. Next was Guido Herspink, and he presented the ALIGN study, atrasentan in IgA nephropathy. And just to outline, so we had a great session actually on clinical trials in GN with Jonathan Barrett, Nicola Thomas, and then Jürgen Flöge. And the first speaker was Jonathan Barrett, presenting data on IgA nephropathy and recent studies. And what he showed was basically the avenue we have seen. So in green, the actually licensed or available treatments, and in gray here, those treatments which will come to the market soon and will revolutionize treatment of IgA nephropathy. So ALIGN was a phase 3 trial. It's not done yet, but they randomized 340 patients in a 1-to-1 per stratum to atrasentan 0.75 milligrams daily for 132 weeks in comparison to a matched placebo. And that is basically the cohort they are analyzing for the primary endpoint. And that includes 270 patients. And then they had a second cohort where they actually investigated if the use of SGLT2 inhibition in addition portends some beneficial effects, but this is a sub-study of this ALIGN study. So as mentioned, 340 patients in the intention to treat analysis set, and then 270 patients randomized for the interim analysis, either to atrasentan or to placebo. And here on the left side, you see that 10 patients actually discontinued treatment in the atrasentan group in comparison to 22 patients in the placebo arm. The baseline demographics, a bit in comparison to what I've shown in the C3G study, was pretty much well balanced. And this actually included the UPCR, which was 1.4 gram in the atrasentan group and 1.4 gram in the placebo arm. eGFR was around 60 milliliter in both arms, and you can see that most patients actually had a RAS inhibition at baseline. This is the top results, actually also presented as a company release letter before, and you can see that atrasentan could reduce the proteinuria by almost 40% in comparison to minus 3.1% in the placebo arm. Again, a highly significant finding in favor of atrasentan. What they did then was to look at specific adverse events of special interest, which is important if you investigate a drug like atrasentan. And what they've seen is that none of the patients had cardiac failure. Fluid retention was almost balanced, so only a bit in favor of atrasentan, something we were worried about. Vasodilation or hypotension occurred a bit more frequently, but again, not significantly more often. Subjects with any treatment emerging adverse event of special interest were numerically higher also in the atrasentan group. But if you look at moderate or severe ones, this was well balanced between both cohorts. So one can conclude that atrasentan was effective, but also pretty safe in patients with IgA nephropathy. The next study, and this is the last one I will present, is a very interesting one. It's the ADAPT trial. It's run in Denmark, and they have used active vitamin D and reduced dose of prednisolone for the treatment of minimal change disease. And you can see here the allocation, 0.5 milligrams per kilogram in comparison to 1 milligram per kilogram. And it also aligns very much with what Professor Huber said before, that we also need to revise our treatment strategies, and maybe patients with minimal change disease need a lesser dose of steroids actually to achieve remission. Active vitamin D, the rationale behind is that a lot of studies have indicated that active vitamin D can actually reduce proteinuria. They looked at two primary endpoints, rate of remission and the time to remission, and that was defined as UACR below 300 milligram per gram or a UPCR of below 400 milligram per gram in 2 consecutive tests. These are the results. So remission rates were equivalent, so 89% in the higher dose corticosteroid group in comparison to 83% in the lower corticosteroid group plus active vitamin D. And also the time to remission was similar, but as expected, the cumulative prednisolone dose until you achieved remission was actually, of course, lower in comparison to the standard treatment. And this is it, and I'm happy to take questions or discussion.
Yeah, thank you, Andreas. Maybe starting with the latest trial, the ADAPT trial. I wondered, where is the control arm without the alpha-calcidol, so the lower steroid? And now, after what Tobias has shown us, we have now 2 drugs with vitamin D, which has as many targets intracellularly as steroids. So why are we going in the unprecision medicine now? And it reminds me somehow on all this vitamin D fairy tales about 10, 15 years ago in renal transplantation, where they wanted to go down with calcineurin inhibitors. And of course, it faded away. The patients were hypercalcemic and there was no benefit. So I want to be a little bit realistic in this case.
Sure, I agree with you. I don't really get the rationale to use active vitamin D, but I like the idea to use actually 0.5 milligram of corticosteroids. Just to give you some background, so there is also a rituximab trial running in the UK. It's a very pragmatic trial called Turing, and they have also implemented 2 different corticosteroid regimens. So one actually having basically a cumulative dose, which is 1 gram less than the standard treatment. And 70% of the patients actually received this reduced dose steroid arm. So I think we as physicians are vigilant that what KDIGO is recommending is way too much. And we can go with a lower dose of steroids, plus minus adding in rituximab early on in minimal change disease or B-cell depletion, as mentioned by Professor Huber, makes perfect sense.
But do you do this right now in Hamburg, in Zurich, in Innsbruck? So going right now for lower dosages of steroids, or would you, for the time being, still stick with the elder regimens?
As of now, we do stick with the guideline-based regimens, but if we earlier add rituximab, then of course, or we add rituximab, then we can very quickly taper steroids. So I think the goal needs to be for medicine at all. I mean, steroids are wonderful. It's a wonderful medication with very pleiotropic effects, but we know how severe the side effects are. So I guess in the era of precision medicine, we need to get rid of medications like steroids that affect basically cellular signaling and immunological signaling at all levels, and we don't even know at what levels in which extent. So it's certainly, as Markus would say, an anti-precision medicine therapy.
So may I ask a question? This has really been fascinating. And with regard to precision medicine, even the anti-B cell therapies are not very precise. And I'm wondering, Professor Huber, how close are we to really targeting pathologic anti-nephrin antibodies per se?
This is a good question. And Nicola Thomas from Hamburg was giving a very interesting outlook on how to target antigen specifically B cell. So this, of course, this would then be precision medicine at some time point if we not deplete all B cells, but just the B cells that are secreting the antibodies directed against, the autoantibodies. And this is not an easy path, but in vitro, and Nicola Thomas is one of them. Maybe we're first now for membranous was shown it in vitro with B cell clones, that he is able to deplete antigen specifically B cells. So this will be just concretely to your questions. This would be the precision medicine here.
Because conceivably you might not need steroids or any of this stuff at all if you could get it right.
Absolutely.
But potentially CAR T cells would also be an option.
Yes, yes.
Absolutely. Now I'm talking about T-cell mediated therapies like CAR or CAR with AACAAR. This is exactly what I was talking about. Absolutely.
But the main issue is the production, because I think over the shelf they are not available, and at least in the very experienced centers it takes 2 weeks to produce the CARs for yourself. And I think in the meanwhile you need, for most of our autoimmune diseases, you need some form of treatment. Maybe not so much for, let's say, FSGS or also minimal change disease, but still you need something. And then you, of course, all this, we also need to question these induction treatments they are using in hematology, because they are pretty toxic, and we eventually would like to avoid that, right?
And Andreas, what do you believe regarding iptacopan? I mean, one thing would be, because everybody has some C3 patients and we are really frustrated with them. When do you think it will enter the clinical reality? And of course, second, it will be, I think, costly. I heard in the US it will cost maybe more than 500,000. But do you think it will be the magic bullet for C3 nephropathy?
Yes, I think there is another company on the market or coming to the market. They are also recruiting C3 post-transplant. But to circle back, I think first off, you need a good pathologist who is actually diagnosing C3 appropriately. That's the first point. And a big issue, actually, at least what we are facing, is we get misdiagnosis. And that's definitely then not good if you consider a treatment which is very expensive. Iptacopan has definitely some beauty. They have also shown that, for instance, the C3 level goes up by 200%, and you get an almost normalization of the terminal complement complex. So it's definitely very effective. And as these patients present early in their lives, so most actually in their childhood, I think this is definitely a game changer. The question will be, of course, A, if you can stop it, and B, when can you stop it, and see if we have basically biomarkers predicting when to stop these treatments, because that's always this important last question when it comes to costs. And I think, you know, considering what Valerie is doing in terms of inequity, I think this is really a limited, a drug which is limited to only those countries with higher resources. And then there are countries like the Nordic countries, which are really placing cost effectiveness at the highest priority. So, for instance, it's not easy to get approval for Avacopan in Sweden, Denmark, Norway, and Finland, which is not so expensive, but we are talking here about a drug which might cost basically twice as much as Avacopan.
On this issue, I would have another question for you, Andreas. So regarding IgA nephropathy, and you were showing a nice chart from Jonathan Barrett, and now another, you know, many more drugs entering the IgA space, not just atrasentan, but we heard about basically on the immune-specific side, we will have B-cell targeted therapies, we will have complement targeted therapies. Then on the chronic progression side, we have now sparsentan, atrasentan, SGLT2 inhibitors, RAS blockade. So how are you gonna choose for each individual patient and tailor all these 8 to 10 medications, which we will have soon be available for an IgA patients? How are you gonna tailor which one to use also in terms of cost effectiveness? What do you think would be the best ideas?
I think this is a perfect question. I think one of the things which struck me is there is a very recent publication from Sweden. And in contrast to the radar analysis, which stopped at 0.44 grams as a cutoff, they actually analyzed what does it mean to an individual patient to normalize albuminuria. And so they could show that these patients had an excellent prognosis. So this, if you take this argument, you need to say basically what we need is to have a maximum treatment in terms of antiproteinuric treatment options. So I think you will have a combination of different things. And it also depends how expensive, for instance, sparsentan or atrasentan will become once they become available. But I think this is the backbone of treatment. And then you will need some form of immunosuppressive, immunomodulatory treatment, which is affordable, but it's also effective. I don't think that target release budesonide has any role because it's non-innovative. It's very expensive. It's around 100,000 euros for 9 months. Plus, it's just delaying what you're then seeing, so a chronic progression of CKD by 12 months. So once you stop it, basically the disease is back in full force. So it's just delaying the progression, but it's not treating the disease. What we need in IgA nephropathy, in my opinion, is then we need to have a second arm. So the immunosuppressive arm really needs to target inflammation, really needs to target the disease. And I don't see it so far. I don't know what the iptacopan study will show then, but I've been basically presenting in a parallel session to the flow session. So I heard Jürgen Flöge talking about CD38 again. And what he showed was a phase 1-2 study, which is really interesting because Felzar actually 3 months of Felzar treatment achieved that patients were stable over 24 months. And what he also showed is that IgG and IgM is coming back pretty much after you stop treatment. But what struck me is that IgA remains actually lower throughout the follow-up. So this might be basically the first treatment we are seeing, which is really tackling the disease in comparison to the others. But clearly we have a huge portfolio here, and we will see, you know, what's then actually the most, I think, potent treatment for this disease.
Just wanted to say if the Felzar, because as you saw in parallel, Georg Böhmig and his data also published in New England, it wipes out chronic humoral rejection. It would wipe out all the other combinations because combinatorial, there are, I think, 68 combinations for IgA now. And if you have such a root cause that you are tackling, maybe all the other combinations will be wiped out.
But I think just coming back to what Professor Huber had said, this idea of phenotyping the patients very much in detail, because I do think we need to try to stratify, because not everybody's going to need all this. You know, in some patients, obviously, it's relatively indolent. So for me, I think that's exactly what you said, was just this idea of monitoring closely, phenotyping. I do think that it would also help if the average clinician thinks a little bit more physiologically, you know, that we all understand actually what these drugs are doing, because often you notice something in an individual patient and it kind of clicks, you know, for certain things. I just had one other question, just briefly, as a comment about the steroids and the anti-nephrin antibodies, because I'm an adult person working in pediatrics. And I realize, well, actually 2 questions. The first is, at least in Zurich, a large amount of our nephrotics are actually from Sri Lanka and other places. So I'm just first wondering, you know, what you have in terms of ethnicities. But my other thing that I find interesting is we do this massive amount of steroids, and there's argument between 4 weeks and 6 weeks in children. You realize it's really an on-off. You know, some of them are admitted like massively nephrotic, and then within 2 or 3 days, the proteinuria is just gone with the steroids. But when they relapse, we give high dose for like a couple of days until it's negative. And so sometimes it's 3 or 4 days of high dose steroids, and then we very rapidly step down. And I'm just not sure why a relapse out of the blue in a child that's not on maintenance therapy should be treated differently to the primary event, you know? So I also have been wondering if all these truckloads of steroids that these children get are really that, you know, are really, really necessary. And I think the response that I've seen with rituximab, it definitely takes longer. It's obviously more resistant children that are getting the rituximab. But so that's why I sort of think there must be some intrinsic impact of the steroid per se on the podocytes, in addition that the rituximab may not have. But I'm not sure. Did you look at ethnicities? Because
I can go through your basically 3 excellent questions in one comment. So question number 1 was the ethnicity. Our adult cohort was not very multi-ethnic, coming out of Rome and Bari and Hamburg, to be honest, less than 20%. Our pediatric cohort, which was coming out of Paris, was much more multi-ethnic, up to 40%. So the true answer is we didn't have a fully balanced ethnic cohort, and it will be very important. That's one of the future trials that we need to better understand the genetic architecture. And we know that there are also different GWAS hits for nephrin depending on different ethnicity. So much more things to learn about. Also, not just on the nephrin itself, but also on the immunological genetic architecture. Both need to be learned and to be brought together. So I love that you bring it up. Number 1. Number 2, your remark on this explosive onset. I think this fits well with you also, you know, entertaining the physiological thinking. We can inject these antibodies into an ex vivo perfused organ or in an in vivo in an animal, and within minutes we have proteinuria. So this is a really functional interference with the filter. It opens it up immediately by mechanical interference with the structure, how the nephrin cysts and transbind, but also on the signaling events that we induce. Your question number 3 comes to this loads of corticosteroids. And I think, you know, as we are sitting here, we need to get rid of these massive loads of corticosteroids that we are applying, particularly to kids and adults. And for that, we need these more precise interventions, be it B-cell targeted. But now the second half, I think, of this question also is this relapse. They usually quickly, kids really have a very different timing dynamics than adults and respond much quicker to steroids. And once they respond, we can start tapering. And then, you know, there were ones that once we taper, they relapse or after. So there are different dynamics being based again in the B-cell biology, which we need to understand better. I think many of these relapses, by looking in the cohorts, which, you know, we would love much more granularity in terms of the clinical information, but it appears that, you know, many of these relapses are also triggered by some kind of infections or respiratory tract infections, which probably then re-trigger the B-cell immunology.
So I don't want to stop the flow, but I will hand over for the last bit.
Yeah, thank you very much. I mean, we are very proud to have Katherine Tuttle with us. We were all in Stockholm amazed. And I mean, Katherine is a key pacemaker in the area of CKD and especially diabetic kidney disease. Personally, I'm always happy to read a publication of her because they are so concise and positive, and I like this very much. And yeah, you were also presenting, so to say, also the summary how we can implement now these different strategies that we have in diabetic kidney disease. And there was some quote which reminded me somehow on diabetic kidney disease. It's like waiting on a bus station in London for hours for a bus and nothing comes. And then all of a sudden 4 buses are coming at one time point. And yeah, so please I hand over. Maybe you can summarize these excellent results, and I'm sure we have some topics of discussion on these fantastic results.
Sure, I'm happy to do that. So what I thought I would do is recap for you what we did present at the ERA and add a little bit more context as well. So again, getting back to the problem that we are trying to solve is that diabetes is the other pandemic in this world. And 537 million people, more than 500 million people worldwide with diabetes. So again, we're going now from the rare to the very common. And in fact, Peter Rossing presented this, that the projection by 2045 is this will be 783 billion, but there's been an even updated projection from the International Diabetes Federation that by 2080, this will be over 1 billion people in the world. So despite what we know about diabetes prevention, which really should be the holy grail, truthfully, it has not translated into communities in a meaningful way. So for the foreseeable future in our lifetimes, there are going to be more and more people living with diabetes on this planet. And living with diabetes means living with diabetes complications. And currently, 4 out of 10 with type 2 and 3 of 10 with type 1 will develop kidney disease attributed to diabetes. And that's now half of all CKD in the world. And one of the things that we were very conscious about when we designed FLOW was really, what are the risks of having kidney disease? And as nephrologists, you know, we've been very nephrocentric, focusing on progression to kidney failure, which of course is a very important outcome. But truthfully, 9 out of 10 people die on the road to kidney failure. They never make it. And that's because of the extraordinary competing risk of death. And this is mostly cardiovascular events, but the second leading cause is infection. And I'm bringing that up because the FLOW trial really gave us a lot of information, not only on cardiovascular events, infections, the things that kill people on the road to kidney failure, as well as kidney failure itself as an outcome. So this was the basic study design. It was a fairly typical population with type 2 diabetes, GFR between 25 and 75. If the GFR was between 25 and 50, we allowed a UACR as low as 100. Those with a GFR over 50 had to have UACR over 300 milligram per gram. And then a very typical primary outcome, which was kidney failure or 50% GFR decline. And then again, very consciously, we put in death from CV or kidney causes because these are complications of living with chronic kidney disease in people with type 2 diabetes. I won't belabor it, but you can see the protocol outline on the right side of the slide. This trial was stopped early last October 13th, 2023 for clear positive efficacy with a hazard ratio of 0.76. And what I will say, I could say a little bit more here than when we were on the formal stage in Stockholm, is that the DSMB basically made a recommendation that it would be no longer ethical to continue to allow people to receive placebo with the kind of results that they had seen. That's a very strong statement for a data safety monitoring board. And then along the tick boxes, we hit every one of the hierarchical confirmatory secondary outcomes, including GFR slope, cardiovascular events in the form of MACE, myocardial infarction, stroke, and cardiovascular death. And then to me, the most impressive thing is the reduction in all-cause mortality. That's a bottom line result. So again, with regard to the composite kidney outcome, this was highly positive, total GFR slope, MACE, and all-cause mortality. Here's the primary outcome. And there you see the difference between semaglutide and placebo. And we'd also like to point out the extraordinarily high event rate. You can see that by 3 years, 20% of people in the placebo group had one of these events. These are the individual, or these are other composite kidney outcomes that we had pre-specified just to show you the results are robust, no matter how we would have conceivably described the outcomes. So without CV death first, we use 40% decline instead of 50% decline. If we do the 4-component outcome, adding all-cause death, very robust results, no matter how we combine endpoints. As you know, different trials use different endpoints, and we did this to just explore the what ifs if we had done it different ways, but no matter how we did it, it was very strong. Here's the GFR slope in the placebo group. And there you see in the semaglutide group, there's a lot of debate over what that little tiny dip of about 1 ml per minute means, probably not much. I would also point out to you that there are very small numbers out at the end of the time point, and look at how much the sample size drops off in the placebo group. That's because of the death rate. So you also have the issue of, this is a survivor bias here. The people who were healthy enough to live were the ones who stayed in the cohort. So that's a really important nuance that I think is not appreciated widely. This is the cystatin C GFR, which eliminates concerns about potential loss of muscle mass with weight loss. And you see a very consistent result. And in fact, at the same time point, 156 weeks, where there's still a reasonable number of people in the cohort, the estimated treatment difference is almost exactly the same. It was 3.30 with creatinine and 3.39 with cystatin C. And I'll also make another comment about the weight loss because everyone likes to perseverate over that. It was 4.4 kilos in people who started at about 100 kilos. This is not, and just being in the US, I think in imperial terms, this is someone who's 220 pounds who goes to 210 pounds. These are not people who are wasting away by any stretch of the imagination. This was not a weight loss study. It was only 1 milligram. It was not the higher dose used for weight loss. And even if you look at the weight loss studies, these would be in people who don't have kidney disease, but the studies were done with either semaglutide or tirzepatide or other like agents for weight loss, where you see 20 to 30% body weight loss. In DEXA studies, DEXA scan studies, 80% of the weight loss is fat, and then the lean body mass is not all muscle mass loss. There's adipose loss that's non-fat loss of tissue that is not the fat component of adipose tissue, so that even in the big weight loss studies, only about 5% of the weight loss is attributed to muscle mass. So I want to mention that because this is the thing everyone is perseverating on. So it's very unlikely that this treatment result is attributed to loss of muscle mass in heavy people with type 2 diabetes who have very modest weight loss. So there you go. You see, either way we look at it, we get almost an identical result. Now, again, remember, what problem are we trying to solve? What are the risks of people with diabetes and CKD? Well, the more immediate risk is actually a myocardial infarction, a stroke, or death from cardiovascular causes. And here we see a very robust result, whether you want to look at the absolute risk change or the relative risk change, hazard ratio of 0.82. And I will remind you, they were getting optimal therapy. Not only were almost all of them on ACEs or ARBs, almost all of them were on statin therapy, and the vast majority were also taking an antiplatelet agent. And here, to me, the most important outcome of all-cause mortality, reduced by 20%. And note the extraordinarily high death rate in this population over a short period of time. Hazard ratio 0.8, 0.10. In nephrology or any field where we treat patients with highly fatal conditions, it is very difficult to show an all-cause mortality benefit. And a 20% death reduction is enormous. This is a strikingly positive result. This is, to my test of reasons, one of the biggest wins we've ever had in nephrology for people with the most common cause of kidney disease, because you have to be alive for any of the other stuff to happen to you. Also, within the safety focus, there were no new safety signals, but what I would like to point out is we really were very concerned about the effect of COVID-19, since the trial was, a large portion of the trial was conducted during the pandemic. So this was an outcome of special interest, and we were both surprised and happy to see that there were actually fewer COVID-19 related events and deaths in people who received semaglutide, represented in blue, compared to placebo. And then, of course, a reduction in major CVD events reported as AEs, as well as in the primary outcome. And I'll also point out, while this is just an AE report, there was no higher rate of acute kidney failure. And if there was any difference, it went to a lower rate. So these drugs in people with CKD do not increase risk of AKIs, and we had no increased risk of severe hypoglycemia. So, okay, I'd like to just remind you that this was a very high-risk group of patients. They had long-duration type 2 diabetes. Neither their glycemia or their blood pressure was optimally controlled, and a high comorbidity burden of prior atherosclerotic events and heart failure. 95+% of people were on an ACE or an ARB, but about 15% were taking an SGLT2. And median UACR was about 570 and eGFR about 47. So a very high-risk group of patients. And if we look at this from the standpoint of the KDIGO heat map, and again, reminding the nephrology audience that yes, this is associated with higher risk of kidney failure, it's also calibrated to higher risk of CVD events. So that across the board, 93% of the study population were at high or very high risk. And I think that played out in the data that we showed you based on the event rates, particularly in the placebo group. So bottom line is this: the number needed to treat to prevent one primary kidney outcome was just 20. It's a very, again, robust response. One MACE event in this population, 45. And then the number needed to treat to prevent all-cause mortality was just 39. We also did a meta-analysis to place the FLOW trial in the context of the prior cardiovascular outcome trials, which had reported kidney outcomes as secondary outcomes. And here, the composite outcome we used to align with the cardiovascular trials was either 40 or 50% GFR decline, GFR less than 15, kidney replacement therapy, or death due to kidney disease. FLOW was heavily weighted in this analysis because we selected people for high kidney risk. But overall, you can see that the FLOW results are very consistent with the overall results in the meta-analysis of about a 20% reduction. And then if we want to look at true kidney failure endpoints, I will remind you that none of these trials, including FLOW, were powered to look at kidney failure as an individual endpoint, but rather as part of composites. And what we see here, again, is a consistent response. Kidney failure hazard ratio reduced to about 0.84 or 16% relative risk reduction. And again, heavily weighted by FLOW with a very consistent result. So now really we have 4 pillars for diabetes and CKD, of course, our conventional RAS inhibitors, SGLT2 inhibitors, and finerenone. And now we think that the flow data clearly solidifies semaglutide as a 4th pillar. And this comes from a paper that I had the pleasure of co-authoring with Valerie for the World Kidney Day editorial. So the good news is we have therapies, but a challenge ahead of us now is awareness, detection, and intervention to the vast majority of people who could conceivably benefit from these advances. Only 7 to 20% of people are aware of the CKD if they have it. And then when we look across different processes of care or conventional risk factor goals for either blood pressure or A1C, we're really falling short. Particularly SGLT2 inhibitor use, and even RAS use here that may look reasonable, about 70%. If you look under the hood a little bit further, remember that most data on medication use are from a single point in time, looking at prescription rates. And in the Cure CKD registry, we took that a step further and asked in those individuals, if we follow them over time, how many persisted on therapy even just 90 days? So here you see ACE/ARB use at 70%. That's where that number came from in the paper that Valerie and I co-authored. But at 90 days, this had fallen off to 40%. SGLT2 use and GLP-1 use. Again, this is in the 2019-2020 period, but even at this point, we had emerging data on SGLT2 use that supported their use in people with CKD, yet only about 6% were prescribed one. And although the numbers are small, you see the trend to fall off over time, and GLP-1 use, the same thing. So semaglutide, I think we can clearly say, saves lives, hearts, and kidneys. CKD is in people with type 2 diabetes remains common and deadly. We have highly effective therapies now that reduce risks across the board of kidney failure, cardiovascular events, and death. And we've clearly established now in flow that semaglutide really has the full package on reducing kidney outcomes, cardiovascular outcomes, and death in this population. We do have the 4-pillar approach that I just described to you. The big but is that low awareness, detection, and access to care are major barriers to the people who need these therapies receiving them. And we really need effective strategies now for implementation to improve outcomes in this enormous global population with diabetes and CKD. And of course, we're very grateful to the patients who signed up to be participants and join the experiment to answer this important question, and all the people who did the heavy lifting at the sites, global experts from around the world who guided their regions and their sites in staying on task and doing the study robustly, and our data monitoring committee who gave us good advice, and of course the events adjudication committee that gave us the opportunity to really confirm the fact that these events were the real thing and are very robust results. And then of course our paper published online in the New England, it received a lot of popular press too. There was an independent commentary written in Nature. It made the front page of the New York Times. It also made CNN and ABC News in the United States, and on and on and on. So I think it just reflects the importance of this result, not only for medicine and human health, but also for science in general and for the public. So I do think this is really a moment in time. It's not just a nephrology result, and I think this is really one of those pivotal points in medicine. And it's wonderful to see how much happened at the ERA from rare to common diseases. But I think I saw somebody on a Twitter feed call it a renaissance. It truly is. And a lot of the things that you were talking about with regard to glomerular diseases apply here. Now we have I think the very welcome challenge of figuring out what drug, when, how, what combinations. Do people need to be on everything? But a few years ago, we would have never had this conversation because we didn't have anything to offer. So I think we're at a remarkable time, and that's the future. That's the next wave of research, and a lot of great people can get involved and help us answer those questions. So thanks, and I'll stop there.
Wow, Katherine, as always, wonderful presentation. And that's why I'm reading so eagerly your publications. There's such a positive momentum there. And I think at the end of the day, you save lives, and many of them. I have only two questions. First, will the guidelines for DKD be rewritten soon? And if so, should we align with the cardiologists with systolic heart failure that every diabetes patient should have the 4 pillars? And if so, should this be independent of HbA1c and more importantly, independent of BMI? So should a diabetes patient with 24 BMI also get a semaglutide? And the second question, because we saw such a remarkable reduction in cardiovascular death, could you envision that most non-diabetic CKD patients maybe also should get, because they are high-risk CV cardiovascular patients, should they be maybe also on semaglutide?
Okay, so the first question regarding guidelines, I surely hope they're going to be updated and that they should be updated quickly. To be honest with you, I have been involved with this KDIGO group for a long time, and there is a plan to do them. One of the problems, I would say, or challenges, I would say with KDIGO is it's so slow. It takes like 2 years to go through their very rigorous process, which I admire and I appreciate. That said, American Diabetes Association, I believe the European Society of Cardiology, American Heart Association have mechanisms to do rapid updates when there's a landmark trial that should be practice changing. You know, with all the caveats that time should be taken then to do a more robust follow-up, but I don't think you can really argue with these results. So yes, KDIGO is going to do an update, but I hope that there will be a mechanism to take less than 2 years to update this guideline. Again, I think that broad interest in this and the impact is so profound. If we wait 2 years to change the guideline, it'll take, you know, X number of years after that to even change practice. And it's probably something Valerie will comment on because we both took a very strong stance on that in our editorial. We need to move more quickly. With regard to will we see the guidelines say that people should be on all 4 therapies aligning with the cardiovascular guidelines? To be honest with you, in these high-risk groups that were in flow, I would say yes. I do, though, want to hearken back to what we talked about in the context of the previous presentation. In the era of precision medicine, I don't know that it will stay that way, because I think Valerie brought this up. There's some low-risk patients who might do fine on an ACE inhibitor. But then there are high-risk patients who may need the full court press and more. Like, for example, people who have a persistent inflammatory phenotype, however we may want to define that. There are different ways to do that. May need additional anti-inflammatory therapies. But I think that nephrology of the future is going to look more like clinical oncology. So if we use breast cancer as an analogy, we used to think, like many years ago when I was a young doctor, it was sort of treated like one disease. And then with the type of precision medicine approaches that we've been discussing, we now have many phenotypes from very minimal therapy to very intensive therapy. And I think that that's where I'd like to see our field go as well, where, you know, if somebody who gets diabetes and kidney disease has persistent albuminuria and perhaps other biomarkers that indicate certain phenotypes, maybe anti-nephrin antibodies. I don't know. You mentioned that in type 1 diabetes. Maybe that's part of diabetic kidney disease, particularly in type 1, which is an autoimmune disease. I don't know. That's an interesting question. And if we have anti-nephrin therapies, would that person get an anti-nephrin therapy? That's the future. That's now we have things to work with. We can figure this out. And then the question was non-diabetic CKD, I believe. So there are trials now ongoing applying either conventional GLP-1s or GLP-1s plus GIP agonists. So for nephrologists, that means glucose-dependent insulinotropic peptides. So in the metabolic world, this has added greatly to weight loss and the glycemic efficacy. But in secondary analyses, the effect on albuminuria and stabilizing GFR is even more profound than a single GLP-1. And those studies are already going into obese populations without CKD. We're doing one of them now. So I think you're right. That's where the field will go. That's what historically our pillar therapy started in diabetes and then spread broadly. And Andreas, I think you showed this for IgA. These are the safety net underneath the specific immunologic therapies, right? Because once you have an immunologic injury, The other thing that happens is inflammation and fibrosis becomes self-perpetuating. And because we don't intercept people at the onset of disease, maybe we will in the future, even in IgA nephropathy, you can give the specific IgA therapy. Let's say you can mitigate the immunologic injury. Many people still progress because of ongoing these self-perpetuating pathways. And that's what we're hitting with the 4 pillars. So back to your question, Marcus, I think these will be, if you will, the safety net for non-diabetic forms of CKD, and maybe even these rare glomerular diseases that progress even with resolution of the immunologic injury. So I'll stop there because Valerie needs a turn.
Much rather listen to you. No, I think it's fantastic. I mean, I think it's beautiful. And I think, you know, the way that you just put this all into such practical, pragmatic bottom line, that these people are dying also of cardiovascular disease. And I think that we absolutely mustn't forget. I think we are better than others in monitoring and managing cardiovascular risk factors, but we really mustn't forget that that's actually what's killing most of our patients. So this holistic, and I think we as nephrologists have this advantage that we do tend to think, I think, a little bit more holistically than others. So my question in terms, just 2 things, because I think we've always thought the cardiologists were so much further ahead of us because they have these huge trials. We don't need to do angiograms in all these people. So should there not be some sort of a global database? Because I think as we just keep hearing, you know, this individual phenotype, and if we get the individual phenotype of everybody, we're eventually going to be able, through AI and through everything else, to really try to understand this person has X score of whatever risk factors, and they are going to do much better on, you know, this combination of medicine. And I feel like in a way we should almost have an obligation to share patients. You know, I feel quite strongly also when we're finding all these strange mutations without known significance and everybody's just, you know, putting it away in a drawer. I believe there's a strength if we could put all things together. Obviously patients would have to agree, but maybe even, you know, anonymously. A lot of hospitals I think now have these general consents. So I think we need to think about that, because I think also what Tobias so beautifully showed, or Professor Huber, sorry, so beautifully showed, was really collaboration, right? It's really this value. And I think in basic science, people realize more and more that they need these people with their little special expertise and the way they can invent, you know, a new assay or something to solve a problem. I think we need to understand that as well in clinical practice. My one issue with a lot of these studies, and I think also in Flow, there was only about 4% Black people, right?
Right.
So, you know, my huge problem is a lot of these studies, they are fantastic, wonderful quality. I understand that one has more trust in the clinical research system in certain countries, but we're never going to get a better clinical research system if we don't start doing some of these trials now in lower resource settings. And we need to know, because, like, for example, SGLT2 inhibitors also similar, about maximum of 8% of Black patients, and not one trial done in Africa, for example. Some were done in India. So, you know, I think we need to also start thinking, we've always complained women were not represented enough, kidney patients in general not represented enough, but now within the kidney patients, we need to represent everybody, plus children. And I realize that's more difficult, but I think there's also this group, you know, and more obesity, etc., in children, and type 2 diabetes in children. It's going to become a huge problem in places like India. Sorry, my little diatribe.
No, Valerie, I totally agree with you. And first, on the registry issue, you know, I am the PI of Cure CKD in the US. That has over 5 million people in it. And we are very interested in working with anybody who can use the data to learn from it. And I do think that there's a lot of power in that real world data as a complement to the, you know, the most detailed omic data to phenotype people. We can clinically phenotype people much better than what we do now. And it's both. And I think these resources could be, that could be the real renaissance, is pulling that together with the deeper biologic phenotyping. Because there are many things that happen to people that aren't biological, right? The environment that they live in, the disadvantages people may experience in certain situations all influence health. If we could capture that holistically, that's the big wow to me. With regard to clinical trial diversity, I totally agree with you. And in other studies that I'm working on, this has become a very intentional focus. So in the US, one of our challenges is the lack of trust, especially in Indigenous people and Black or African American people. There are many efforts afoot to improve that. We can start by providing an invitation, but not everybody wants to come to our party based on historical injustices, which we cannot immediately solve all by ourselves, but we're aware of it, which is a first step to figuring out solutions. And then with regard to clinical trial sites in disadvantaged or underrepresented communities worldwide, one of the studies that I'm involved in is using a mentorship program, because part of the challenge has been lack of infrastructure for doing clinical research, even with the best of intentions. And so there are some efforts afoot now to pair, for example, there are some experienced investigators in South Africa, to pair them with other people in Africa, South Africa, or other countries who are new to clinical research as satellite sites for mentoring, to establish the pathway into what you're talking about. So it'll take us a while, but if we don't start now, we'll never get there. But those are some efforts. I just want to respond to you. I totally agree. And I'm sure we can do better, but there's at least recognition, effort, and attention being given. And that's how I think we could get started going in a better direction.
I think this is great, and we could probably discuss like 3 more hours, because nephrology is having such a momentum, as I said before, and the renaissance is ongoing. And I think with what Valerie said, we are hosting Vivek Chan, so I think we can continue with these discussions and how we can roll out clinical trials internationally, not only India, but also Africa. And again, John Barrett showed that one trial only in IgA nephropathy is on the African continent. I think we need to do better, and we need Valerie and others actually to really nag us and nag the pharmaceutical companies to do that. Is very important. And with this, I would like to thank all the speakers and Markus and Gunnar and Valerie for the discussion. And thank you, Tobias Huber and Katherine Tuttle, for great presentations and very powerful results, which are very relevant for us as nephrologists. And with that, I would like to thank all of you.
Thank you.
Have a nice evening.
Thank you.
Thank you.